2 years. It is 3 decades of research which has come to a conclusion that deafness is a neurological emergency, and the children who are born deaf should be implanted as early as age of 9 months. So the candidacy for adult has changed to partial hearing loss, and children who were implanted by the age of 2 years now are implanted by the age of 9 months. Just because the neuronal connections are best by the age of 2 years, 85% of the learning occurs before 2 years, and hence there is a shift in the intervention timing. So the Joint Commission of Infant Hearing, which would say the rule of 1-3-6 has come down to 1-2-3, that is by the end of 1 month you must do hearing screening, by 2 months you must do a complete hearing evaluation, and by 3 months you should start the intervention. It is also extended to dysplastic cochlea. I remember when I started doing abnormal cochleas, everybody would criticize that she uses the font for abnormal cochleas, but now there are workshops on abnormal cochlea and how to implant them. We also are doing cochlear implant with other disabilities and syndromic cases, but you have to take care of each associated anomaly, and you must give them a guarded prognosis depending upon the associated disability patient has. It is also extended for patients with labyrinthine ossification, because ossification of the cochlea occurs following a bacterial meningitis. It can occur in far advanced autosclerosis. It can occur following a otitis media and following trauma. But in all these cases, you put a depth gauge, see whether your depth gauge is entering the cochlea or not, how much it is going. Depending upon that, you decide whether you will do the implant or not. And in those patients where you are waiting for funds, you can probably use that as a dummy electrode too. There is also possibility of using a double array implant when the space is not enough. One part of the implant can go through basal turn, part can go through the middle turn cochleostomy. Cochlear implant can also be done in advanced autosclerosis, but we also have experience of doing the implant in the cochlear autospongiosis, where the bone was absolutely spongy, and it shows like a hello sign where you almost feel like a double cochlea. But in this, there is a possibility of insertion in the wrong side, because you can go just outside the basal turn because of the spongy bone. You can have incomplete insertion, you can have facial nerve stimulation, and with the success of unilateral, it is promoted to do bilateral cochlear implantation because of several advantages. God has given us 2 hands, 2 legs, 2 ears for some work, and having a binaural hearing makes the whole of a difference. You can do bilateral cochlear implant either sequential, or you can do it simultaneously depending upon availability of the funds and condition of the child and experience of the surgeon. Coming to the most important aspect, that it is also offered for patients with who has partial hearing. So any audiogram which fills into the black shades, you can do a hybrid implant where there is a combination of hearing aid and cochlear implant, and you should do several steps to preserve the existing hearing. There is a recent advance in the form that you have a smart navigation system. In fact, KEM is the first government college where it has ordered smart nav for even 5-2 electrodes. So you can put a smart navigator. This is a navigator which you fix it during the surgery and then introduce the implant. Everything is seen on the iPad when you are introducing, and it looks something like this. That during the time of insertion, you can see how the electrode is going, what is the speed of insertion, is there any kinking or not, whether there is a tip fold over or not. So during surgery, the iPad reading tells you how the implant is going in. And once the insertion is done, you can see the placement and NRT on the same iPad. Here you can, the lower part shows that how is the speed of insertion, whether I had any jerky movement or not. And once you have this, at least you save the time. You did not require intraoperative C-arm immediately, because that causes increase in the time of surgery. It is also, cochlear implant is also offered for single-sided deafness. We have an opportunity to implant a doctor, an engineer, and give them a binaural hearing. We'll come to their indications. If the hearing loss is less than 10 years, you can give them the option of cochlear implant. Otherwise, you can give the option for BAHA if the hearing is more than 10 years. Hearing loss is more than 10 years. So to summarize, early implantation as early as 9 months is recommended. Even if low frequencies are normal and high frequency hearing loss is there, one can implant. Single-sided deafness should be given option for hearing in the other ear. Cochlear implant can be done when there is anomalous cochlear associated disability with guarded prognosis. Bilateral is better than unilateral implantation, and success of surgery is completely dependent on post-operative therapy and parental involvement. Coming to the recent advance in BAHA, you all know that BAHA is a good device. It is a bone-anchored hearing aid. The concept was for patients who have conductive or mixed hearing loss. Our largest indication is bilateral microtia anotia patient, where you cannot wear conventional hearing aids. We also offer this to patients with bilateral cholesteatoma who have got bilateral cavity where hearing aid is not the good option. And some of our patients have taken up this for BAHA. As I already told you, single-sided deafness of duration more than 10 years is an ideal indication for giving a BAHA. Before you do the BAHA, you must do a workup. You can really give them a feel of hearing by giving a trial. This is the only implant where you can give trial. My entry into the whole system was when I heard the trial, I thought it is fantastic for patients with microtia anotia, and it works wonderfully. So you give them the experience, you can see the startling experience, you can hear so good, and it's very easy to convince the patients. The BAHA there is an evolution. Initially the BAHA was percutaneous devices were there, but we had problems in the form of infection and surrounding skin growth. So came the passive transcutaneous implant in the form of BAHA Attract, where there's a magnet on the inner side as well as outer side. And after Cochlear has taken over the bone conduction devices, they have come with Ossia device. Ossia works on the principle of piezoelectric device, and it helps give a real-time hearing to the patient, and everything doesn't work at the same level because you have an implant at the level, another level, and the coil and the magnet is at the other level. Pointer dena please. And if you come to passive versus active transcutaneous device, where there's nothing coming out of the skin, the take-up is far higher than something when it was coming out of the skin. There is a difference in the thickness. You can see that the passive devices are protruding while the active devices are very slim and they just get merged in the hair. So this is how the evolution of BAHA has occurred. These are the percutaneous device and these two are the transcutaneous devices. So the transition from percutaneous device to passive device has allowed many more people to come forward for using this device. We have patients all around us who are struggling with hearing and hearing aids. They all should be given this option, and we should be able to make a difference in the life of these patients who are struggling with hearing loss. Coming to the surgical steps, you basically mark the implant and then you go 1.5 centimeter in front of that. Here you are going to do infiltration only along the incision line because you want to see the thickness of the skin. This is the marking for the implant. You do that with methylene blue. And skin thickness is measured. Any patient who has got skin thickness less than 3 millimeter, we need to wait. So it is 3 to 4 millimeter is good. Then the incident site is infiltrated. This is one incision which you take to create a pocket for the implant, and you elevate the periosteum.